joined by my colleagues today, Katie Burkett and Carrie McDermott, and we want to thank you for joining us. This Friday Focus for Health is hosted by Great Plains Quality Innovation Network, the Centers for Medicare and Medicaid Services Quality Innovation Network, quality improvement organization for North Dakota and South Dakota. Today's webinar is being recorded and will be posted within 1 to 2 business days on our website at Great Plains Quinn, greatplainsqin.org under Friday Focus for Health. If you have questions or comments, please feel free to add them to the chat throughout the discussion. And we do keep a running resource list that will also be available on our Friday Focus for Health page. This is the final week of this series on chronic kidney disease.
Hey, Grandpa! Hold on.
We have somebody who needs to mute their microphone, please.
I just took care of it, Lisa.
Thank you. The last 3 Fridays, Dee and Katie have provided information about the recommended treatment and data related to chronic kidney disease. The goal, of course, is to prevent chronic kidney disease, and in the event it does occur, we want to manage it appropriately to prevent progression to end-stage renal disease. And today we'll talk about it from the patient perspective and share what she experienced living with chronic kidney disease and the care that she received. Several years ago, I was managing an accredited diabetes education program, and SB presented for care. This case was a few years ago, but I know her personally and I know her daughter, and I called them and visited and got their permission to share her case, even though we're keeping her name confidential, but also wanted to refresh my memory on the details of her case. So she was about 80 when she came to us. She had longstanding type 2 diabetes. Her A1C was about 9.5%, and she was on oral medications. She had hypertension, chronic kidney disease, obesity, COPD, and arthritis. She lived in a rural community of about 1,600 with her husband. Her daughter lived nearby, occasionally helped her out, but she was generally able to manage her own care. She received her primary care at the local rural health clinic and critical access hospital, but she had several consulting specialists that were at the tertiary hospital, which was about 90 miles away. And this was back in the day when telemed visits were not very common. So if she had to go to an appointment or needed an appointment, it was usually, she had to physically get there. So take a minute, review this basic information and keep it in mind because we'll need it in just a minute. I want to do an age-friendly care assessment, and you will recall that this directs the care to be patient-centered. We'll go a little bit out of the usual order here. And looking at her mobility, she had COPD, obesity, and arthritis, all which caused some limitations and made it hard for her to get around. When we think of her mentation, she was able to understand her treatment instructions and managed her own care. Her daughter did help a little bit once in a while, maybe running to get prescriptions and stuff like that. And then for medications, there were many considerations related to her chronic disease and her chronic kidney status. She could generally manage her medications on her own, and she didn't want to use insulin. Now, when we think about what matters, I want you to recall the details of her case, and then we'll just do a poll. And given the information on SB, what would you guess is what matters to her? Carrie, if you'll populate that poll and go ahead and add your response on what you think matters to her, and then it will populate in a word cloud. And maybe I'll back up just a second so you can see her information. What do you think matters to her?
And Lisa, I'm not sure if you can see the results, but they're coming in. Okay.
Yeah, I see some answers coming in. Care, family, independence, quality of life, spending time with their family, staying home, all good answers. I gotta jump back through these again. So let's see, a few more seconds, maybe. Independence, mobility.
Staying home.
All good answers. So what mattered to SB was her knee pain, so mobility, as somebody said, and she wanted to avoid insulin. Those were the two most important things to her. And then we can't forget about this sneaky little line down on the bottom, to align care to what matters the most. So she had chronic disease, which required visits to several specialists, but the problem of most concern to her was her knee pain. So she found an orthopedist that agreed to do a knee replacement. Her daughter told me that. She's the one who found the orthopedist. Her primary care person did not find it, that sort of thing, but that's was important to her. So she found somebody who would do that procedure for her. But when she went to her pre-op, guess what the orthopedist said? He said, we can't fix your knee. Your A1C is too high and your kidneys are too bad. Her GFR was 15. Does anybody remember what happens when your GFR hits 15? Anybody want to respond in chat? I'll give you a hint. It's not good. We'll review those in just a minute. But once your GFR hits 15, yep, thanks, Carrie, you need dialysis. And so that's what they recommended to her, said, you know, we can't fix your knee. You need to go on dialysis because your kidneys aren't working. And the fear of dialysis motivated her to get control of her blood sugar and thus attempt to improve her chronic kidney disease status. I did borrow Dee's slide here from week 2 just to review that GFR guideline. And you can see once your GFR, it gets down to the teens and 20s, you're looking at severely decreased kidney function and kidney failure. So the recommendation will be to have dialysis. SB was very adamant that she wanted to avoid dialysis and was confident she could get her blood sugar under control, and she wanted to avoid insulin. So then she presented to us for diabetes and diet education with a very complicated prescription for her diet. But she said, I remember distinctly her saying, I can do this. I know I can do this. And we had to develop a diet for her to manage her blood sugar, and keep her kidneys healthy. So we needed to limit her protein, but also manage some other nutrients like sodium, phosphorus, and potassium. And her magnesium was low, so we needed to have a high magnesium diet or help her maintain or improve that. So this was a very complicated diet for her to follow. But she did do pretty well. The doctor had told her that she would need dialysis in a year, and she managed to extend that to 3 years. She does now live in an assisted living facility and receives dialysis 3 times a week. But I do remember she put forth a really good effort, and she came into us. She had her notebook full of her blood sugars and the foods that she ate and some other little notes of things that maybe happened with her health throughout the day. So she really committed herself to making the changes that she needed to do to improve her kidney or maintain her kidney status. So when we look back, SB could have really benefited from better organized care. Her care was so fragmented. Her primary care was in her home community. Her diabetes care was outside of her community, and all of her specialists were outside of that community as well at that larger referral center. So there were many different players in the game. It was very hard to coordinate her records and really understand her overall health status. To me, there was a really glaring gap with her GFR. You know, that didn't go from 50 to 15 overnight. That really should have been addressed and explained to her, because she really did pay attention once dialysis was mentioned as a recommendation. And also her medications should have been addressed, and making sure she was on the appropriate medications with the kidney protecting features. There's some hypertension meds, the ACEs and the ARBs and some beta blockers, and then diabetes medications also. There are some that have kidney protecting features, the GLP-1s, SGLT2s. And then she should have been removed, had some meds removed that she shouldn't have been taking with that decreased kidney function, namely her glyburide, because that's metabolized through the kidneys. And I knew that, and that's what I learned, that should be stopped. And I believe I called her primary care provider, and one of us called her nephrologist. And the answer was, well, her diabetes doctor needs to take her off of that. And that really kind of surprised me to hear that answer, because he's the kidney specialist. He knows what happens in the kidney and what happens when certain medications are processed through the kidney. And I really thought they would have made that recommendation to stop that medication, but they said no, they were going to leave that up to the diabetes doctor. So getting back to what matters to SB, perhaps if someone had asked her what mattered to her, and they said, okay, if you want to treat your knee pain, let's work together on that. We want to see you get your knees fixed. So let's make a plan. That could have been an incentive to her to manage her diabetes and make those changes to fix everything. And it could have given her higher quality of life for a longer period of time, and hopefully could have avoided dialysis. So when we look at leaving an action, assess your practice or assess your patient population. Gather your data to see how many SBs are in your practice. And there are many complex patients just like her. Look for patients that are at risk. Look at your females, your Native Americans and African Americans, and your patients with diabetes. Those groups are all at higher risk for developing chronic kidney disease. What's your plan for those that are at risk? What's happening with their care? What is one small intervention that you could do to find and help someone like SB? Let's also break the silence. Too many times we talk about diseases that are silent killers, like diabetes. We know that there's a large portion of the population of people that don't know they have diabetes. The same is said for high blood pressure. That's also called a silent killer. 1 in every 3 adults, this is a North Dakota statistic, 1 in every 3 adults have high blood pressure and don't know it. And the same thing is happening for chronic kidney disease. As many as 9 in 10 adults with chronic kidney disease do not know they have it. Let's tell them. How about if we tell them that they have it so we can do something about it? Use your data to decrease or even eliminate chronic kidney disease, but especially prevent it from progressing to end-stage renal disease. Here are some resources that will be included on our resource list. Again, that will be found on our Friday Focus for Health page. And now we'll open it up for discussion, and we'll start by asking a couple of questions.
So Lisa, for this, I broke this into 2. I hope that's okay.
Yeah, that's fine.
Okay.
So first of all, we're asking, how could a chronic kidney disease initiative or change package have made a difference for SB? We shared some plans earlier in the month. Or any quality improvement package. Maybe you're calling it something different. Monitor your labs closer. Standard practice, medication management, manage your knee pain, monitor meds, all good. And I had written down early screening and identification, monitoring, addressing disparities, appropriate meds, diabetes education, dietitian consults, and asking her what matters and helping her get to her goal. And use your data to address those at-risk populations. How about what interventions can you recall from the last 3 weeks that could prevent or improve CKD? Would you do anything else there? Teamwork, good. That's a great answer. I think a lot of the answers are the same. Care choices, medication, the screening and identification for sure. Great, thanks for that feedback. Not any one right answer. There's a lot of different things that could be done. And then now that SB lives in an assisted living facility, and recalling what I shared about her case, what comes to mind for her care in this facility? What will she need? Diet education, facility dietitian, renal diet coordination. Again, her care coordination will continue for sure. That's right. So the dialysis itself is a big commitment. Now, I actually forgot to ask if the family has to transport her to dialysis or if the facility does. That's a big commitment for both the family and the facility. 3 days a week, they have to go to dialysis and it takes 4 or 5 hours. So that's either a drain on family resources or the healthcare resources. We know in the assisted living facilities when staff workers the workforce is short already. And if we have to commit to something like this 3 times a week, that could really be a stress on staff. She's also a high risk patient, so she's a potential risk for frequent admission or readmission. And just maintaining her higher quality of life, she'll probably be very fatigued. She might not be able to participate in some activities. She still has some independence living in an assisted living, not a skilled nursing facility. So a lot of concerns for her care, a lot of big commitment for her family, and as well as the healthcare facility where she resides. And then I'll pause here for any other thoughts or questions or input that anybody else might have related to this case, or if you've seen a patient like this and what the outcome or what was done for a patient that you know.
I think what comes to my mind is it's just the importance of knowing your patients and your clientele. I think that's the biggest thing. I mean, some things do happen and, chronic kidney disease can happen, but are we catching it? And, of course, our goal is not to be an end-stage renal disease. So, sometimes we miss labs and sometimes we, forget medications that could be, but it's just so important to have those with that pre-existing and the comorbidities to be coming in and having that good care and really looking at your policies and procedures and or algorithms, whatever it is, to make sure that you get those nephrology referrals when needed. The primary care providers have a lot on their plate, but I think that's why it's a team approach that everyone needs to be watching the patients, and put some safety nets in there.
Right. And I see we have a comment in chat about helping the patient and family advocate for themselves if we are unsuccessful when reaching out to the provider. So that's a really big part of it, I think, is learning how to advocate and how to ask the question for themselves. I know we have a few people from the nursing home population on here. Any thoughts from you? And how you would manage chronic kidney disease or any cases that you've had or any experiences with residents that are on dialysis?
I don't work in a nursing home and I haven't, and I didn't have any patients on dialysis, but when you think about it, a lot of the long-term care facilities don't always have that van or that transportation. So I would say it's a lot of coordination, to make ensuring that 3 times a week. And we always have to think about if they're in a nursing home, a lot of times there's, it's a wheelchair, it's their, it's not so easy to load them up. And we live in the Dakotas. And so there's that good old weather, so it's just really a lot to ask of that patient.
Right. I do have a friend that manages a dialysis unit, and she shared with me with the situation with workforce. She was very short-staffed, and so they typically were open 3 days a week, and she had to move their schedule around so they learned that they had to adapt as well because they didn't have enough staff to take care of everyone in 3 days. They had to switch to a 6-day schedule so that their staff could, they could fit everybody in because they couldn't do their usual and get as many patients in that 3-day schedule. So they had to learn to adapt as well. And Carrie also said, okay, Deborah, thank you, said some skilled nursing facility has on-site dialysis, which avoids transport and time. That's awesome. I don't know how many there are. I was looking at the facilities that are in North Dakota, and when I think of that map in my mind, I am not sure if is that in North Dakota or South Dakota, Deborah?
I think that's in South Dakota. It's through
Okay.
Sanford.
Okay.
And they have several, they call them dialysis dens.
Okay.
And they live directly at the nursing home, get their dialysis there. It's nice because you're not doing the transport. You don't have to worry about the weather, the
Absolutely.
time. You know, they
Right.
could just come down after breakfast or whatever, have their
Right.
dialysis and go back to their room.
Yeah.
So it's getting to be a newer thing to look at. So
Yeah,
we're trying
that's
to push
awesome.
that. Yeah,
Yeah,
I really like that idea.
that's great coordination of care. Yeah. And then Carrie also says periodic medication review is also important to try to prevent further kidney damage from chronic med use as well, right? And Lori said, yes, Sanford in South Dakota has a few on-site dialysis settings in the nursing home. So good. That's really good to know. That could be the case in Fargo as well. Fargo has 3 or 4 dialysis units, and it's possible there's one there as well. I just wasn't aware of that. All right. Well, thanks everybody for that feedback. That's about all I have. So unless anybody has any other comments about chronic kidney disease and case management.
Lisa, this
Yes.
is Tammy. I just had one other thing when you stated, just making sure that people know that they have chronic kidney disease. I have 3 family members just in the last 2 years that didn't know that they had chronic kidney disease. Like they have so many specialists, specialty docs
Mhm.
and that primary care that they didn't know until just one random maybe
Mhm.
a new internist that they had an appointment with. One was actually she was having a gastric sleeve and she went to that the GI surgeon. And he was like, how long have you had chronic kidney disease? And she's like, a what? It's like, I didn't know I had chronic kidney disease. And one's my mother-in-law, and she's 80
Mhm.
some years old. And, it's like physicians, why aren't you telling people their diagnosis? And that's one thing that I think is very telling, that when people don't know what they have, and maybe some education on how to manage that.
Yeah, and I think so. What I feel like I've seen happen. So I worked in been a registered nurse for going on 30 years now here shortly, and I feel like sometimes a primary care provider tries to protect the patient, if that's the right word. They'll tell them what their lab work is, so they might have told them what their GFR or their BUN, creatinine, or the albuminuria results are, but not necessarily telling them what that means. I found the same thing in diabetes when we were doing some quality improvement and when we started a diabetes support group. So then I asked for a report to be ran of all patients who had diabetes. And of course, that's defined by a certain blood sugar or a certain A1C. So we ran that report, got X number of patients, sent out a letter and said, hey, we have a diabetes support group. We got the same thing. I didn't know I had diabetes, or I don't have diabetes. My doctor never told me that. So I think that is really important, that, the numbers are one thing, but tell them what they mean, give meaning to the numbers, and,
Exactly.
again, if you find out what matters, so if it's anybody who wants their knees fixed, great, let's help you fix them. But before we do that, the surgeon is going to want your A1C to be at this level, and we got to make sure your kidneys are healthy and that sort of thing. Also, that could be a good driver for smoking cessation, because we're hearing that some surgeons won't do certain procedures if people smoke. And so it'd be nice if we could get that collaboration of care all around to do some of those things. Thank you for that discussion. And so our July series will be coming up, and this is on working with multi-visit patients and reducing preventable ED visits and how to do that. And these will continue on Fridays in July. They'll continue to be recorded so you can attend the live session or watch them on demand. So be sure to register for those. Yes, and a reminder, there's no Friday Focus for Health next week because it's a holiday weekend. We encourage you to join our Community Coalition listserv. And as always, we very much value your feedback, so please complete the evaluation using the QR code or the link in the chat. Thanks everybody for the discussion. I very much appreciate that, and we'll see you in a couple of weeks.
Bye.
Thanks everyone.